Good evening. Welcome, everyone, to our monthly Mastery webinar series. This is Lauren Lefebvre with Treace Medical Concepts. And like I said, we are very excited that you have joined us this evening for our monthly Mastery webinar, where tonight we will feature case presentations and expert panel discussions surrounding the Treace family of 3D bunion procedures. So we will hear a ton of valuable and really insightful information from our panel here. About each of these procedures that we offer and a little bit more as well. So without further ado, I would like to, here's our traditional company disclaimer here. I will introduce our esteemed faculty of surgeons here, Dr. Easley, Dr. Relation, Dr. Troxell, and I will turn it over to you, Dr. Easley. Good evening.
Thank you, Lauren, and thanks for putting this together. I'm excited to have Kurt and Ronnie with us here. So I just want to emphasize that as we go to the agenda, that we want to focus on the core principles. And there is if you've been to a course, you understand there's a philosophy, but we're going to focus on the procedural algorithms. So we'll take it through this family of procedures, all of which have their own specific indications, but also you'll see some overlap between them. So when we want to focus on these, even if something seems like it would be a little different, they still focus on the same core principles. And the idea is to have an instrumented way to correct forefoot deformity and midfoot deformity. And that is streamlined and it's reproducible. And the goal also is to have the patient weight bear early. So while the instrumentations may be interesting to you, or maybe you've used it and you have more to learn, the goal is always to make it easier for the patient to recover and get them on their feet as quickly as possible, because we do believe that that is good for outcomes to promote that. And so we're going to talk about today. The three of us are going to go through this, and we'd love to hear your questions, so we'll answer those as well. We're going to take it from traditional Lapiplasty all the way through the nanoplasty, and then MTP joint arthrodesis, which has a triplanar correction, and then adductoplasty, and then times you might have to arthrodese even more combine these, where you take the first ray and arthrodesis completely with a double, or do a 3-2-1 and add the first MTP joint as well, or a quad as we call it. So this is the algorithm. If you've been to a Treace course, you'll be familiar with this. So we're going to, each time we introduce one of these concepts that you're most likely familiar with, we're going to then follow the algorithm here. So what we're starting with is Lapiplasty or nanoplasty. I'm going to turn it over to Kurt, who is going to tell us about micro-quad. And also, if you have to do a little extra correction in the toe itself, the Speed Akin. Kurt?
Sorry, I was muted there. Nice to see everybody tonight. So, yeah, thanks, Dr. Easley. It's the Lapiplasty with micro-quad and Speed Akin we're going to go over first. So this is a 57-year-old female, long-standing bunion, retail manager, on her feet all day long. The one kind of wrench she threw in here was that she's a smoker for the past 40 years. Gave me some hesitation. We did discuss the fact that I would definitely want her quitting prior to doing the procedure.
Was it easy for her to quit? I'm sure she's quit 100 times before.
Right. So this was a motivation for her, and she is currently not smoking, but we'll see how long that goes. So, but you know, someone's in a lot of pain, and it's a motivating factor, because I tell them, listen, I really don't like to do these procedures if you're going to be smoking, because it's going to throw a whole lot of potential complications into the mix. So. We're all looking for a good outcome, and that can help. So procedure selection on this, I looked at the joint itself. She had good range of motion. There was no catching or crepitance in the joint. She did have a pretty good size eminence there at the dorsomedial aspect that you could see on the oblique. So I wanted to do more of a traditional Lapiplasty on this case. However, I tend to go smaller incision, but based on her smoking history, I figured we should probably get some more stability. So the micro-quad had just come out, and I thought that would be a good option for her. I let her know we would assess the first MTP intraoperatively. to get that eminence down. And then I always look at the Akin as an option once I get my correction completed for the IMA. So just going through my fluoro shots here. This is after I dialed in my correction, and you can see my temporary fixation is still on this image. I just wanted to have this one in here to kind of show how I do my temporary fixation for these procedures. So I typically go crossing smooth wires across the first TMT and percutaneous transverse wire from M1 to M2. I typically put my positioner back on when I'm doing this, and then I run my wire just distal to it, just to act as a guide for that wire. Then I remove the positioner because I'm doing these percutaneously with about a 2.5 centimeter incision. And then I also wanted to note that I throw that proximal medial to, distal medial to proximal lateral screw or wire as my screw guide. So you can see on the lateral view the orientation of that screw going from that base, the plantar base of the first metatarsal and heading up into the middle cuneiform. So I usually use that wire as my temporary fixation to save a step down the road. And then you can plate around it as well.
Can you go back one, Kurt?
Yeah.
Can you share with the group just some tricks to fire that screw? It's great that you show the orientation, but how can you make sure that you don't hit one of those tines, mainly the dorsal, microquad, the main tine there, as you come across from the first metatarsal into the cuneiform, that you don't hit that and it didn't deflects or limits you in getting that screw across, or you could compromise your fixation with that dorsal microquad?
Yeah, that's a great point. So I have this wire thrown initially, and then when I go to put my microquads or my anatomic quads or doubles, whatever I'm using for that particular case, you can look down the guide for the quad or whatever device you're putting in, and you can actually look right down the drill hole and see if you're going to be hit anywhere near it. If the anatomy is forcing you to put your fixation in a particular place, you can always rethrow this wire. So once you have one of your, as long as you have 2 points of fixation, you can take one out. So if it's going to be in the way and block you, you can always usually put in your quads or your speed plates, for instance, around the wire, and then you can always remove that wire and rethrow it if it seems to be in the way.
Perfect, thanks.
Yeah. And then I always assess for an Akin afterwards. So if it looks like sometimes when you have these long-standing deformities, there's some adaptive change to the metatarsal joint, and it kind of pushes that hallux over. So in this case, I did want to get a little bit extra correction. And this was my first instance with the Speed Akin from Treace, and I was really impressed with it. It was a very familiar concept with the speed plate style fixation. It was very smooth. There wasn't a lot of fiddle factor. I've used other implants in the past, and sometimes they can be a little tricky from the back table for your scrub techs or nurses to hand off. This was very smooth, very familiar. The insertion was very, very seamless, and same kind of steps. You can go to the next slide there.
Kurt, what was your normal fixation for Akins before using the Speed Akin? Were you always kind of a staple construct? Were you a crossing screw, or what was your go-to?
Mainly I was doing staples, and more recently had switched to the MIS with a burr and a single screw. If I'm opening the joint anyways to get the eminence down, if there's a large bump like in this particular case, I'm open regardless, so the staple is a nice option. If I'm doing more of a MIS style case or a micro Lapiplasty and I don't have to touch the first MTP, then I'll do a burr and MIS Akin with a single bevel screw.
Yeah, and Kurt, just to be clear too, this is still like a speed plate, right? So
exactly.
As you can see there in the second that picture, you can see that it still activates. So you put it in just like you would a speed plate, and then you pull the cap off, and it still activates, right?
Yeah, I have a slide on that at the end of this case.
Oh, good. Okay, got it. Perfect. Got it.
Yeah.
And I want to make sure people saw that convexity too.
Yeah, I did one today actually, and it really is impressive how it just contours right to the concavity of the phalanx. So there's no prominent hardware there at all, which is a lot different than the other staple type constructs that are out there.
And not to spend a ton of time on a Akin, but I'm sure most people out there have experienced doing a staple for something like this, and depending on the product, sometimes it can be hard to disengage that if you don't have a bunch of helpful retraction in there. And I've actually had the Cortex snap on just trying to remove the inserter for a staple. So, the insertion of these is much easier than kind of twisting or torquing a staple once you put it in there.
Yeah, I rarely have to tamp these down. They just kind of go in by hand most of the time. So, go ahead. So just quick on my post-op protocol. So she's only about, she's in her 5 to 6 week out right now. I'm going to see her in a couple weeks for her 8-week visit. But I initially have kept her heel touch in the cam walker for the first 2 weeks because of the smoking history, basically. Normally I walk these people at 5 days. But she presents, so there's your sequence of images there, pre-op, 2 weeks post-op, 4 weeks post-op. There's no weeping or anything from that dorsal scab. That's just some, the strap from the boot tends to rub there a little bit. So, but that wasn't bothering her at all. She has really no pain. She's walking in the boot at this point. She's doing a range of motion exercises on the hallux and on the first MTP, and it feels good. So we're happy with how it looks so far. Head to the next one. So here's the pre and post-op. That's a 4-week post-op image. So, not a ton of consolidation yet, but I wouldn't expect to see much, but everything so far looks great. Alignment, I was really happy with. Overall position, you can see that 90-90 construct with the micro quads and that plantar to dorsal screw.
I want to make one point too. If you go back one, that lateral X-ray and follow-up, you would look at it and say, it looks like the first ray is elevated, but could you just explain to the group that at 4 weeks, that's probably not the case? What is actually happening?
She's guarding a little bit there. If you look at the hind foot, look at the subtalar joint and the TN and the CC joint, that Sima and you can see that she's supinating the foot. You can compare to the pre-op image. So she's not putting full weight down on that at this point. The overall alignment, you can see if you look down the Miri's angle there, the talus to the first met, and it's pretty much dead straight. So once she actually starts putting more weight on that, that's going to level out.
Yeah, I think that's an important point. Good. Looks great.
Thank you. So yeah, just to reiterate, we talked about this earlier, but the Speed Akin it's a speed plate. So it goes in just like a speed plate does. The images here show you the positioner and the drill guide. The preload and insert is just like your traditional speed plate. It's just a miniature version, 9x9. That the difference here is the curvature to the dorsal bridge, and that really is nice. Really sits really smoothly along the medial cortex of that phalanx. And then the microquad. I've been really impressed with this. It really is much more stable, in my opinion, than the traditional double. It just feels really, really stable when you put it in. And I do like the fact that there's 2 lengths. In this case, I believe I used a long time dorsally, and then I've been doing a shorter time medially on most of these patients. But you can still do it through a 2.5 centimeter incision. So another great product.
Try Nano.
Nice. Well, thanks for doing that. I'm going to run you guys through just a PSI case I did recently. So still Treace concepts, and we're still along the algorithm, but just some newer techniques that you can use. So you look at it here, pretty standard hallux valgus deformity. In this particular case, not a whole lot of rotation, but if you have access to a CT scan, it doesn't have to be a weight-bearing CT scan. In this case, it was. You can get a really accurate reading of what the rotational correction needs to be in the frontal plane. So next slide. And it comes like this. So there's a Treace protocol, so that can be properly interpreted by the team and the engineers. And it basically outlines it for you. And you can meet with the team, and you should meet with the team. But they will learn what your preferences are pretty quickly. And if you decide to choose this route for your correction and surgery, then they can actually follow what your protocols are. And it's basically doing the surgery before you step in the operating room. You know exactly what your target is in 3 planes. The difference here is that we're used to, if you've done Lapiplasty as your operation, you're used to correcting before you cut. In this case, you're going to deviate from that. So the algorithm is the same, but this step's a little different in that we're going to look at the deformity and we're going to cut before we correct. But we've already done the correction. It was just based on pre-operative three-dimensional analysis with the CT. So let's go to the next slide. So this is what the plan looks like. So you can see here there's a cut guide made based on the plan in my three-dimensional correction I want to achieve. The final correction you can see on the right, but it's not corrected on the left, and this is how the cut guide's going to sit. And then you look at two planes really right now, and it's still, the details are being worked out. There are different ways to look at this, but the concept is, you know, look down the metatarsal. So on the picture at the top, on the left picture at the top right, you can see right down the two holes, which gives you an idea of the metatarsal cut. And then I'm looking at the cuneiform on the top left picture on the left image there, and or left page, and so you can see the two holes there, and it gives me an idea. But it's still a cut guide that you can see too very quite well. And this is what we're going to try to match. And that you can see with that I can correct the rotation, I can get the sagittal plane, and I can correct the IM angle as well. So that's the concept. Let's go to the next slide. So this is what it looks like in surgery if you start the video. And the idea here is, see, you have a model. So it comes with a model. If you've done total ankle replacements, you're familiar with this, with the same idea. But you can see here, then I get a feel for it with haptics with the model. And then I open the foot, and I haven't really done any soft tissue releases. I just clear enough periosteum away that cut guide can sit like it did on the model, and drop it in place. So there it is. Let's go to the next slide. And then I have fluoroscopic images. I did put one pin in it, so it throws it off a little bit from my plan, but I hold the plan up and I look at the fluoroscopic image and just confirm really what I'm feeling as being the right fit. And then I get a sagittal view just to make sure you see that I didn't penetrate the plantar cortex with the pins. I just wanted to provisionally put it in place. But then I get those two views I mentioned earlier. And you can see that those two holes in the metatarsal, the cuneiform, are offset because that's how I'm going to correct the rotation. Let's go to the next slide. And so here it is, the guide in place, and you're familiar with this. So this is really just more Treace. I'm just making the cuts, but I haven't corrected yet. So you see the pins are still offset because the rotation has not yet been corrected. And there's an oblique pin, which most of you do Lapiplasty you're very familiar with. Let's go to the next slide. And then here it is. So I've made my cuts. Now I pop it off, and you can see here where I can get that rotation. Remember, this one only had about 6 degrees, but that's what's built into it. So once I slide that off, I did add 2 more pins, so it gives me more stability, and the metatarsal cannot rotate around that as well. So it gives me a little more stability to when I place the compressor. So let's go to the next slide. And you see here, these are cuts that you've seen before. I mean, it's very accurate. It's maybe even more accurate. It's a plane in 3 dimensions. And so it's quite remarkable as long as you put the guide on properly. And again, you have the haptics you can work with the model. And you plan this all before you ever step in the operating room. Let's go to the next slide. And here's the compressor. It looks a little different. It accommodates the 4 pins, but the concept is the same. So I've distracted it here, and you can see here the bone coming out. It's cuts that you're used to, very precise. It's instrumented, just like the Treace system is in the legacy system. Go ahead to the next slide. And so I'm just removing the bone, and you can see here cuts. And now you can see when I put the compressor on, the rotation is corrected, right? Because I've aligned the 2 pins through the compressor. But the pins were offset. Now the compressor puts them in the right position. Now I'm back to basically a Lapiplasty procedure because everything's very familiar. Everything's lined up. Cuts have been made. Rotation is corrected. And now I can do the procedure. The one difference I'll tell you is just briefly is that I don't really need to put a fulcrum in. Yes, I can use a fulcrum like I always have, but with the 4 pins in place, and this already hadn't been corrected, and I base it off of the way the pins are positioned now, it actually essentially as a virtual fulcrum because the 4 pins will hold in that position. So here it is. I'll do my compression. I double check, make sure I have no gapping planarly. Let's go to the next slide. And just like Kurt just showed, my provisional fixation, I'll put my pin a little more proximally, the first to second metatarsal pin. And then these are S4A plates. You can use whatever you want. You can plan it and eventually probably be able to plan it so that those two holes I just pointed out in the picture could actually be for fixation. So in other words, the same pins that were used for the compressor or the cut guide, I should say, and then the compressor could also then be used for the instrumentation. That all can, the implants, that still all can be done. But here, this traditional, so I drop the S4A plate in place. Let's go next slide. And this is what it looks like. So it's what I like about it, it takes a lot of strain out of the system. So when I correct before I cut, there is some strain to make that work. Here, I make the cuts, and it all just falls into place very naturally because the cuts are made, and it wants to fall into place. You see, I did do a medial incision there just to remove that dorsal medial eminence. I did reach through the joint to do a suspensory ligament release, but it's really essentially it's a Lapiplasty procedure once I have made the cuts and put the compressor on. So let's go to the next slide, and I think you get the idea, but I just wanted to show that this is on the horizon. You asked before Ronnie starts, yes, when will that be available? PSI is going to be released most likely in September, so we're still a few months away. So we're selectively doing cases, still learning a little bit more, but keep it on your radar. I think you'll really appreciate the advantages it has and how easy it makes the operation because you can plan everything ahead of time. Just have to think about CT scan, and remember it can be weight bearing. It doesn't have to be weight bearing though. It can also be a standard CT. Ronnie?
That was a great looking case. All right, so I get to talk about nanoplasty. So I was very excited when I heard about nanoplasty, and I did my first case at the end of May of last year. And once we had the re-release, I've been doing quite a few of these. So only going to show a couple cases, but I have a bunch more. If anybody's ever interested, feel free to reach out to Lauren, and we can connect, and I'm happy to show more. So this is a pretty straightforward case for me, 72-year-old male. For me, bunion pain, pretty traditional. I will favor doing a more minimally invasive approach for these bunionectomies just due to the patient's age. I like to walk these patients pretty much day zero. I had been doing other systems before this for my minimally invasive, traditionally more of a Lapiplasty for my bunions, but older patients, 70 and above, I would choose to do the minimally invasive. With the nanoplasty, I'm doing a lot more of these cases now on a broader range of patients. So you can go to the next slide. So this is what the fixation would show. We already touched on supinated x-ray views. This is clearly a supinated one. On the next case, I actually have a video to show you this. Through my first few cases with nanoplasty, I was getting a little confused on my postoperative images because it looked like my implant was super dorsal. Why do these 2, 4, 6 week post-op x-rays look like my implant is sitting super high? And it's due to that supination. So as we've been doing these in the lab and instructing others, I've been really active at showing the video of really going live on C-arm and doing kind of pronation and supination once we're done, just to convince everybody that, hey, no, the implant's in a good position. We just kind of have to trust it. You may see some weird two-dimensional images of this three-dimensional correction. Instrumentation, we have other slides of it. This is as we're progressing. I'm seeing very similar results to doing a bunch of the two-screw MIS bunions. I think the bridging may be a little bit faster, all anecdotal. I have been seeing personally less postoperative pain. I think a lot of that has just been the fact that we're not doing a bunch of poke holes medially potentially. If you have done the two-screw fixation techniques or had experience with that, a lot of times the guides that they have for other systems will fail and you end up freehanding it. So that can relate to a few separate wire throws, which I think lead to a little bit of neuritis or have more of a potential for neuritis. So this is where we're kind of getting at 7 weeks with this patient. He's not quite healed yet. This is one of my more recent ones that I did. You can go to the next slide. This was also a relatively recent patient of mine. Obviously quite a large bunion deformity. Once again, expanding my indications for minimally invasive surgery. 49. This is one that would traditionally be more of a Lapiplasty for me. After talking with her, really motivated to pretty much walk and be active right away. My comfort level with this, it continues to get better almost daily at this point. So I'm more comfortable and confident doing more of the minimally invasive type approaches. So we went ahead and did the nanoplasty along with a minimally invasive talus bunionectomy. So you can see pretty dramatic correction immediately. Sorry for the relatively poor angle and a little bit of blood on this one. But you can see a pretty dramatic correction. And go to the next slide, please. So this is a video. So this basically shows a stacking lateral, and you can see the pronation and supination motion just to see how, as you do that, you'll see your implant ride high and then ride low. The real key with this is to get a good lateral when you're in surgery, really that first lateral there where you're stacking metatarsals, because if you're off in any which way, it will kind of deceive you. And, you know, obviously as we go through the techs and things like that in the lab, you know, there's quite a few checks to make sure that you're not high or low. But I think one of the keys, at least for me, through the first 10 or so of these initially, was really understanding that lateral to see where your implant is sitting, because it can really, or it really did mess with my head to think, you know, patients are doing great, but I'm looking at this image, is my implant high? I don't feel anything. What's going on with it? And it's really just as they come in, once again, they're supinating their foot, so the implant has been looking high. If you're new to minimally invasive procedures, I think this is definitely a starting point for you. I think this is by far the easiest way to do a minimally invasive bunion while still being able to get all the correction that you could possibly want. A lot of the two-screw systems, you know, I've used all of them that maybe aren't the most reliable. Not that they're hard, but it can be pretty unpredictable. If you have 2 or 3 in a day, you know, one may take you 20, 25 minutes, and then you may be messing around with another one for 50 minutes to an hour. So this is pretty reproducible. I think, you know, if you get into the lab and you have something, you know, a good instructor go over this with you, I think you can really cut time with it and know where you're going to potentially, you know, have something that might throw you off a little bit in a real case. But we were part of the team that did the first few of these, so we didn't necessarily have that. Even with that, I think it was a very quick learning curve to it. And I just did one today, and it was 16 minutes. So, I mean, any bunion for me that's less than 30 minutes reproducibly is really what I was looking for in my practice. So I think this really has offered it to me. Results are comparable, if not better, to my minimally invasive bunions of the past. And really the big thing, too, is patients are so happy with these minimally invasive procedures. There's no joint stiffness because you don't have to open up the first MPJ. They're able to walk on it immediately. I'm getting these patients back into a normal shift 4 weeks. You know, once again, these patients are just super, super happy. They send you everybody they know. So all in all, very excited about having the nanoplasty in my tool bag. And so far, all the cases I've done, I mean, every single patient's doing very, very well and very happy with the results.
Hey, Ronnie, could you, Lauren, could you go back? Well, do that first. Yeah, let's do that because we have a question. Yeah, make sure we get to that first. Joel Berryman has a question.
Yes. So the question.
Yeah, I see it. I got it. Without a positioner, how does the PSI?
So going back to the PSI.
Yeah.
Yeah. Maybe we hit on that at the end, Dr. Easley, or you want to hit that now?
Let's see real quick. Without a positioner, how does the PSI system address the frontal plane rotation upon compression at position? Just really quick. Remember, it has 4 pins, so 2 in the cuneiform, 2 in the metatarsal. So there's really no pivoting that happens around those. So it's very stable in that regard. But I planned it beforehand, so the way the cut guide sits, and then you saw the pins, when the pins go in, 2 go into the metatarsal, 2 go in the cuneiform, but they're offset. So that was only 6 or 7 degrees. That one was 6.9 degrees, which we corrected to 0, which I corrected to 0 with the plan. But when it can be more, it can be 20 degrees. It doesn't matter. So the cut guide will have it offset that much. So that's how it's planned. So everything goes. Cuts are made, cut guides removed, and then I put the compressor on. But when I line up the compressor with those 4 pins, it then corrects the frontal plane. And so I don't really need a I don't need anything else there. The rotation will be corrected that way. And then as far as the intermetatarsal angle, that gets corrected because it has 4 pins, so you can't pivot around anything. Yes, I have done this, and I've dropped a fulcrum in. Quite frankly, I felt the fulcrum actually limited how well this corrected without the fulcrum. So when you get a chance to try this, you'll see that it's a much more stable compressor, but everything's already planned, and the way the pins are oriented from the cut guide and from the pre-op plan, it all lines up, and it allows it to act as a virtual fulcrum, and you don't need some of the other instruments you traditionally had to rely on. Yeah, that's good. That was a great question. You'll get an opportunity to do that. We'll find the lab where we can do it, but we're just a little bit off from it, so be patient. Yeah, let me ask you a question about this real quick to Ronnie. That's great. Can you tell the team or the participants, how big is the incision that you make for this?
So the incision is pretty reproducible. It's based on the cut guide, or I call it the bat wing. The cut guide at the beginning of the procedure, I mean, it's pretty much a centimeter or less. I pretty much go right based on the size of that cut guide. Skin marker, front side, back side, and that's my incision every single time. I've never had to extend it. So pretty small incision, usually 1 or 2 stitches there. One thing I have done is I have started opening that little area in a small little layer. So I leave like a capsular layer just to bluntly dissect and make sure there's no nerve in that region. Also, just to kind of close a quick little deep layer over it, because when you do put these in, the head of the implant is right there. So I feel more comfortable having a deep layer over top of that implant, just in case there were to be any sort of wound or dehiscence in that area. You'd be staring right at that screw head. So I do recommend kind of doing a small little layer there. It takes an extra 10 seconds to do, and I think closure ends up looking a little bit better, but very small.
Perfect. Okay, and then Joel Berryman has one more question. We'll do that in just a second. I guess one other thing I wanted you to ask, the small incision, all good. One of the emphasis of all this algorithm is we got to correct the frontal plane. We got to get the rotation right. How do you get the rotation right with this?
It's pretty easy once you kind of get your hands on it. I don't know the experience level of everybody on the call, but, really getting into the lab with this thing, I'm a big proponent just because, once again, doing a lot of the old type techniques, I guess we can call them now the old type techniques. I pretty much make my cut, and then I like to be able to correct it. I should be able to correct it with my hand and a mosquito hemostat. So I broach with a mosquito hemostat. I get my rotation just with my fingers, and I should be able to get all the correction I want within the procedure just with that. And then I introduce the implant. The implant itself with the external guide, it sets you up in any sort of way, shape, or form you could want it to be. You can really dial this thing in. Once again, it's more of a hands-on lab type technique, but there's a rotational pin that we put in when we're doing the cut guide that we're able to have a removable rotational guide with the external guide for the nanoplasty. So you can just sit there and dial it in. I've done a lot of these completely by myself with no extra set of hands, and it's very, very easy to do. You're pinning as you go, so you hold your reduction, which a lot of times with other systems, you're just kind of fumbling around and freehanding, and, it can be kind of a harder than necessary type of case. But yeah, very easy to dial in translation, rotation. DMA is kind of an important part of it too when we're in the lab, showing how to do that. I kind of undercorrected that on the first few cases just through not knowing better, but very easy to correct that and make that perfect every time now too.
That's great. Yeah. So Joel Berryman just wanted to know, what were the points of frustration when first using the nanoplasty, and how has Treace addressed those with a newer nanoplasty system? You answered some of it already, but what were the points of frustration that have now been overcome?
Yeah, that's a great question. One of the first one I did was through a wave of like the first 6 that we've done, and the first one that I did, I couldn't get the external guide off at the very end of the case. The reason for it was one of my distal locking screws wasn't all the way down, wasn't all the way locked to the plate, so it was interfering with the external portion of the guide as I removed it. So that was kind of a quick and easy fix. But once again, if it's one of the first cases, nobody's ever done that before, made that mistake. So figuring that out makes it really easy to not do that in the future. Another thing was just orienting, something new, being able to read the x-ray, know what you're looking for. Like I said, now for me, it's super, super easy to know exactly what I'm looking for, when to check my laterals and all of that fun stuff. But in the beginning, like anything new, it's understanding the importance of, when to check that lateral and knowing when you're good. A couple of my early cases too, getting that oblong screw that goes into the intramedullary canal of the first metatarsal and locks into that implant, making sure that that is long enough to catch that lateral cortex is super important. If you just look at that x-ray, you can imagine how potentially that implant as a whole could migrate medially, and then you would lose some correction. So it's important to snag that lateral cortex with that. Once again, easy when you're thinking about all these steps and you're not super familiar with it, to ignore things like setting the distal metatarsal articular angle. That's really simple to do with the external guide. You basically just grab it along with the hallux and make sure that you're tilting the joint in a rectus position. If you're really caught up with what your next step is and you're not thinking about that, I had about 2 or 3 cases where I think I undercorrected it. At the end of the day, patient's doing well, it looks great, but we're all perfectionists, so we want to see it perfect every single time. So final point to it is getting that rotational correction. A couple of my early cases I under-rotated. I think that was due to the old rotation guide, which has since been adjusted. So I think this one just works really, really well. I also don't hesitate to just hold the rotation myself if I have the fellow with me and have her pin it, just so I know the rotation is set. But these are simple things that we've improved upon. And once again, someone has to make those kind of first mistakes, and hopefully I was one of the few to do so then everybody else can kind of just step in and make them look perfect every time.
Great.
So I'd
Well,
be
thank
curious,
you.
Dr. Relation. Dr. Relation has done a couple nanoplasties, correct? I'd be curious to hear his experience with this as well, sharing feedback as well as Dr. Troxell's. I know you're not presenting a nano case, Dr. Relation, but just your experience anecdotally on what you've seen, like Dr. Troxell's.
Sorry, I had to unmute myself there. Yeah, I've done probably 3 or 4 of these, and two of them are about 12 weeks or more out, and they actually have great bone consolidation already occurring. That whole entire area really fills in nicely. So that's one thing that you don't see on this image because it's so fresh, but you really do see it fill in, which is nice. Patients, anecdotally, they do seem to have better motion at the MTP because you're not going into that joint. Pain has been usually less than the traditional lapiplasty, and I'm walking them right away. So yeah, patients have been pretty happy with it.
Well, good. Well, Lauren, why don't we go to the next algorithm picture and let Dr. Let Kurt keep going with this. So at this point, we're going to go to adductoplasty, but Kurt, you're going to show us about mini adductoplasty and your experience with that.
Yeah, so the mini adductoplasty has really been a game changer for my practice. I really like being able to afford these patients the maximum correction that we can provide, and being able to do it through a 3.5 centimeter incision has been really great. So in this case, this is a typical patient that comes in for me. She's 62. She has some arthritis, also a former smoker, but she quit many years ago, so that wasn't really a concern for me at this point. But comes in with ball of the foot pain. So when you're looking at this, you gotta come in second, sub-second, sub-third, just ball of the foot, overall pain. We take a look at the x-ray, and what do we see? Next slide. So this is what shows up. So ball of the foot pain, bunion pain, not much of a bunion because of the adductus. So we look at this, and I like to use the plumb line technique to really show these patients, and it makes it make more sense when you're trying to explain to them and tell them, listen, we can't just do a bunion on this, because where am I going to put your first metatarsal? So, Jody's really talked about this a lot in the adductoplasty webinars and at the lectures. And we basically take a line at the medial aspect of the medial cuneiform, bring that to the lateral aspect, extrapolate it out to the second metatarsal, and you tell the patient, listen, I want to put your first metatarsal in line with this line. I can't do it. It's being blocked by your second met. So this is a pretty substantial metaductus case. So we look at, how do we go about that? Well, the plumb line technique is nice. I like to show the patients the x-rays, go over it with them, show them the angles, show them the lines. You can go to the next slide. The Treace has a nice brochure on this too for adductoplasty. And it has a really nice side-by-side. So if you're not doing these and you're interested in it, definitely talk to your reps and get some of this literature, because it's a really nice side-by-side comparison. You can show it to the patient. It shows the difference between a bunion with a traditional bunion versus an adductus case. And it really makes it easier to explain to them, why do I need to have 3 joints fused, and to get the full correction. So the mini adducto has made it a little bit easier because it's a much smaller incision. In this particular case, she also had a pretty decent bump dorsally. So we talked about doing a colectomy, and then I always assess for the Akin intra-op, and you can see, Ron, you asked me about this last time in the last case, but this is the MIS Akin that I did because I wasn't open medially. I did more of a dorsal because she had a large, very dorsal bump on this one. So I did an MIS Akin with the single screw. And actually, this was before the Speed Akin came out. Yeah, we can go. So my typical approach to these is I let them start to bear weight when they can tolerate it. They typically have a little bit more pain than the single joint Lapiplasty because you are doing 3 joints across the whole midfoot. But I let them, I tell them, listen, I put them in the splint for the first 5 days. 5 days out, I get them into a boot and tell them they can walk to whatever they can tolerate. They usually are full weight bearing by week 4, and she was with no really minimal pain with ambulation. You see my 5-day image, that first one. And then at 4 weeks is the middle one. And then 16 weeks is the picture all the way to the right. So you see how that incision where the adductoplasty is, it's quite small. It's about 3.5 centimeters and it just fades right out. So you don't have these big long incisions. Really makes it a lot more cosmetically appealing. She was very happy with her foot width decrease. And at 16 weeks, I just saw her 2 weeks ago, and she's doing great. If you want to go to the next slide, you can see the before and afters, I believe. Yeah, so I did 2 hammer toes one hammer toe on her as well, and that was the peak implant from Treace. But you can see the metaductus angle, really getting that corrected and getting a nice straight metatarsal, getting that first metatarsal as Sezone apparatus realigned. And another point to make about the mini adducto, which I believe might be on the next slide, is that you can fit multiple different types of fixation in that incision. So even though it's only 3.5 centimeters, you can do your anatomic quads, you can do your micro quads, you can do doubles depending on the anatomy. So if, let's say, the cuneiform is small and you can't fit a quad in, you can just do the double, but you still can fit most of your fixation through that small incision as long as you place it properly. And that's one of the keys with this. And if you do a lab, this is one of the things we really stress in on the cadavers is getting this lined up just right. So Treace has a great guide for this Cruciate guide. Typically, we put a pin right into the confluence of the first and second and third metatarsal bases, and we draw our line right over that. And I usually start, as long as you have that pin dead center, you're going to be right over the joints, so there's no guesswork, and then you can plan the rest of your incision around that. Makes the case go a lot smoother.
All right, Kurt, go back one slide. I know we got to move along, but go back one more slide.
Yeah.
So you took it to another level. Now, one more slide back. Yeah, you took it to another level. So now you got that same screw coming from the first metatarsal and second cuneiform. But you have fixation in the second cuneiform. So how do you plan that so you don't run into that time?
Very carefully. No, so you just got to. I do under fluoroscopy when I'm throwing that wire. It's nice to be able to look down those speed plate guides and really know where your fixation is going to be. So I'll take extra fluoro shot, make sure that where I'm placing it, it's not going to hit. You always got to make sure you look at your imaging in multiple planes, but I was able to thread that right between those tines without hitting anything, without disrupting my fixation to the second met. I don't think I had to rethrow this one, but yeah, I mean, you just have to, you may have to move it, but it just seemed to, you can usually make it fit. You just got to work your way in there.
No, it looks great. One other question. I know you did some hammer toe surgery, but when you do adductoplasty, do the lesser toes that are starting off in valgus, do they correct without
A lot of
doing
times,
much to the, doing much to the toe?
So if you look at, I only did the second toe in this case. So if you look at 3 and 4, they were pretty contracted in her pre-op image, and her post-op image there at 16 weeks, there's minimal contraction. Second toe was pretty much rigid, which is why I did the correction at that one. But normally I tell these patients, listen, if it's not hurting and they're flexible, let's just see what happens. And a lot of times they do reduce once you get the metatarsals realigned. It takes a lot of tension off that joint, and that buckling disappears.
Great. Well, great work. Looks very, very nice. Let's take it to Ronnie. Tell us about adductoplasty for midfoot arthritis.
Yeah, so I had what I thought were a couple unique applications for it. I don't think most people hear Treace and they think trauma, but I think there is a good application for it. Doing the adductoplasty, I think that the system is just so user friendly, and teaching it and showing it in the lab, you become really comfortable with it, and it really puts you in a great position just to be successful with it. So this is a case of just isolated second and third TMTJ pain, really patient not having any sort of issues elsewhere. So went ahead and did just a 0-degree adductoplasty. So no real need for any sort of correction. That's not her chief complaint. Her chief complaint is just the arthritic changes there. So used the speed graft harvester. Simple procedure. This one I was solo for. I didn't have the fellow or any help with it. Did it myself in maybe 30 minutes, 30 to 40 minutes. Pretty straightforward case. No issues whatsoever with it. I used the speed plates, just the 2-hole for it. I had plenty of room. I could, like Kurt was saying, I could have used the 4-hole option with it, but I felt pretty comfortable with this. And at 3 months here, everything looks good in terms of fusion. This lady's got a lot of other stuff going on with it, but in regards to her foot pain, everything really resolved with it. So, just thinking outside the box a little bit with it. I love the fixation. I love the fact that we're able to do these cases and walk patients right away. I don't think that I'm too old, but when I was in training, really a lot of these, it was very rare to be walking patients immediately. So with these newer techniques and this newer technology, most cases that we're doing outside of trauma really were able to walk patients right away. So this was a maybe a little bit of a unique procedure to do this on, but just to kind of get you to think outside the box, make the procedure easier for yourself. Previously with Liz Frank trauma and Liz Frank fusions, specifically closing down the second and the third there can be a little bit hard, even if you do just a minimal joint resection. Usually you're looking at a gap there, and even with hand maneuvering and kind of that up and out technique, you can still see some gapping. So using the instrumentation that the Treace system offers makes this case really, really straightforward and simple. And then if you go forward, I have another one that I did a few weeks ago. So this was a younger patient. She had a isolated plantar second metatarsal intraarticular type fracture, and this was about 3 years old. So you can see malaligned non-union with arthritic changes into the joint. So this was something that hurt her. Was treated non-operatively just with immobilization and really never got better for her. So she'd been putting it off for quite some time due to just not wanting to have surgery. So we looked at it and we talked about it, and I said, well, I can fuse it and I think you'll do pretty well with it. And she's progressing really nicely. But if you move forward, similar approach. I used the system. Obviously I didn't use any sort of formal adductoplasty cut pad because I wasn't going to interfere or mess with 3, but still using these saw blades and just the compressor to hold everything in place. And then once again, I went with the quad just because of that fracture being a little bit large on the plantar side of the second metatarsal. But doing that fixation allowed me a little bit of extra real estate. I did examine, because it was a suspicious type injury, and I know that's not the purpose of this talk, but I did examine her Liz Frank area, and it seemed that her second met base was tilting a little bit laterally. So I was highly suspicious that to have that fracture pattern without any sort of Lisfranc component, I wasn't really buying it, despite the scans not really showing anything. So in my estimation, she did have a little bit of instability with it. So if you see any shadowing in there, it's because I did put a allograft bone screw as a Lisfranc screw just for an added component of stability in that area in this case.
Very nice. That's good. Well, thanks for sharing that. That's good. Yeah, so arthritis, there are cut guides with the adductoplasty system that are just without angular correction. So you can do that. One quick question, Ronnie, for that. If you do an isolated second TMT, or if you did 2 and 3 without any deformity correction, are there any soft tissue if you use the cut guides, are there any soft tissue releases you have to do in order to allow the two surfaces to oppose?
I think that's a really good question. I think I, just out of habit, I did just a very light release, but I would guess that you probably don't have to do a whole lot. If you were closing the area down after the 0 degree cut and joint prep and you were having any sort of like hold up, then I would say maybe proceed with it. I imagine you could get away without doing it, though. I don't think it would necessarily be a requirement for it just because you aren't shifting or you aren't closing any angle. I don't know. What do you think?
Right. Yeah, no, just my experience has been that if you do it, I think most of the listeners, participants are probably aware that as you do adductoplasty, you got an angular correction, you've got to release the ligaments between 3 and 4 in order for that tether to be released, and then the third TMT joint can oppose. When I see 2 and 3 just straight on, there's a neutral cut guide that's in the set if you haven't used it. I may have to go do a release between 1 and 2 and between 3 and 4 to make that happen, or in this case, like you're showing here, release between on each side of 2, just to allow that the tether to be released. I don't want to destabilize the foot, but it goes against what we usually teach not to release between 2 and 3, but in this case, that allows it to then oppose. But just a thought, I don't know, I haven't really seen where I could do it without it, but I'll come do a fellowship with you and I'll learn. That'll be good. But thanks. It's good. Let's go on to the next in the interest of time. We got our algorithm. So we're going to take it a little bit farther. So MTP fusion or arthrodesis and doubles. So I'll do that. Let's go. I'll try to go through this quickly in the interest of time. But here's a patient with arthritis. So it's not a hallux valgus correction. It could be if it needed to be, but in this case, it's just hallux rigidus or limitus. So let's go to the next slide. And here's the surgical approach, and I think most of you know that. It doesn't have to be this generous, but I think in this case it'll allow you to show you some newer instrumentation, newer implants that are available through Treace. So here, just pretty standard joint preparation. I think most of you know that, so we'll go on to the next slide. And I'm fairly comprehensive with that. So there are McGlamory type release tools, so I'm sure most of you have that in your ORs. But in the kit, you actually have a release tool, and that's actually been worked on too to make it even easier for you, and just standard removing of excess bone. Let's go next slide. And the way I do it, I do a cup and cone reamer system, which if you haven't done this through Treace is available. So I drop that. This is reamers. They come in 23, 21, and 18. And so I just size that, and then go to the next one. And then what I do is I just put it up there against the head, and I get it balanced the way it needs to be. And then I'll actually drive my guide pin through that, so that way it makes it easy for me to center it. Remember, if you make it too dorsal or too planar, that sagittal plane offset can be a problem. So, and there's the reaming, just protecting the soft tissues around it. Go to the next slide. And then here, I just think if I do the proximal phalanx, as you saw that I set that retractor in that Homan retractor. It's just important to make sure that you don't get the tendon. I have damaged the tendon one time in my career. Of course, it was my minister from church. So I really am careful not to I just make sure that EHL tendon is protected. So you see that here, and here's the reamer being used, the opposite side of reamer. So pretty sharp system, does quite well. Then there's a little drill in the system, actually comes with the set. So you can fenestrate that. You used to that from your TMT joints, so just same concept. And then I sometimes use a rongeur to just even break that up a little bit more if it's particularly sclerotic. So go to the next slide. And there it is. And I go ahead and use that as my fixation. I know that not everybody does that, so I'm trying to get an idea, get the rotation right, but get the sagittal plane. That's what I'm after. So I use that same pin that I used to ream as my initial fixation. And then go to the next video there. Yeah, so ideally I'd like to see that it is pinned, so I have to make sure that I'm not being fooled by the pin, but I want to have good contact where it's almost hard to slip the free underneath the metatarsal head and sesamoids, but relatively easy down at the toe, at the tuft of the toe. And that's usually the proper position or represents what would be, represent where I would want to be with the patient standing. Go ahead, next slide. And then I'm going to get the rotation right, so that's what I'm checking here. Next slide. And it obviously can rotate around that pin, so I'll add a supplemental pin. I usually do that from the lateral side, but many different ways to do it. Let's go to the next slide. And I just confirm that because I could still be off on that. Now I'm going to put a compression screw in, but my compression screw is another source, just like we talked about earlier for the TMT joint, but another point of provisional fixation. I can stretch the skin there to do that, but the neurovascular bundle's there, so I often make a separate incision just to drop it in so I'm not taxing that skin, potentially rotating it more into pronation again, and getting the neurovascular bundle. So here's the Speed MTP, if you haven't seen that yet. But it's a system I've really gravitated toward. Yes, I'm biased, of course, but I really like this system. It's good. So I have my pin in for my screw, but I haven't put my screw in yet. And then these are two threaded tacks that then tack that once I like the position. And then just like we taught in for the other techniques, you can look right down the guide and see if there's going to be any provisional fixation in the way. The two threaded tacks hold this in place and also serve as more provisional fixation. So pretty low profile, nice way to get the positioning right, and easy to use. So you see that here. I know that I'm not going to interfere now with my crossing screw that's more plantar because I've looked at it under floor and I know exactly where the 4 tines from the speed plate, Speed MTP, are going to go. And if I have to reposition that wire, then I'll reposition the wire if I have to. But it's sitting where it needs to be, and now I can commit to it. Let's go to the next slide. And so you see that here, so I'm just going to drop that in, drill that. Everything's held in place. If I had a provisional wire that's in the way, I can remove it because inside the Speed MTP guide, I have 2 threaded pins that are holding it in place as well. And then next, just move it forward, then the screw goes in. And you're familiar with this, very standard. These come in 3 sizes, 26, 30, and 34. So you have some options there to make sure you get the right length after you've measured with the depth gauge. If you haven't used the depth gauge, it's a good one. It actually has the countersink on it, so you actually measure off a countersunk depth gauging rather than just putting up against the bone. And then I can peek inside the joint and make sure that screw sits. So, chicken and the egg, what do you do first? You can put the Speed MTP on first. It does activate when it goes on, or you can put the plantar screw first. I don't think it really matters. But I do like putting that plantar fixation, and then I'm going to add the Speed MTP that'll activate and give a little more compression or stabilization to the construct without actually changing the position in any way. So it screws in. I've got my guide in place. Go ahead and go to the next slide. And you can see then there I've got everything lined up in the way that now I've drilled it, so I'm ready to go so I can remove my provisional fixation. Let's go to the next.
Dr. Easley, do you want to talk about what's coming up in terms of targeter for this inner thigh screw here?
Yeah. So if you, I think most of the people on the call and certainly our panel are skilled at putting these screws in by hand. But if you have any question and you really don't want to hit any provisional fixation, any fixation that's going to be with the Speed MTP, there will be a targeting guide that'll make it easy for you, so you can miss it every time. So that's on the horizon. It's not yet available yet. Go to next slide. Go ahead and show that. So you can see here. But anyway, so you can see here I've got everything lined up, and I've got the screw in place. Now I'm just going to drill the holes. I know there's no interference. I did have interference with the provisional fixation, right, the longitudinal wire, so I removed that. There's no reason to have that anymore because you see that fixation in the Speed MTP guide itself. Go to the next slide. And then I'm removing the other, I removed the other wire, but just in case, I'm a belt and suspender surgeon. I don't really need it. I've got a screw. I've got everything in place, but I go ahead and put that wire in just in case. And then just important to make sure I put this in reverse, right? It's a threaded pin. I don't want to snap it off. So I remove that and the guide comes off. And then you can peek and you can actually see the holes, right? So just like any other speed plate, you can see the holes for the Speed MTP. Let's go to the next slide. And then there it is. So it's a little different than what you're used to in that it's a speed plate, but it also has two screws. So it gives you added fixation. These are oblique screws that I think everybody's used to unicortical fixation, but this is a single construct dorsally. So these can be bicortical. So you got different screw lengths here, and I usually use these bicortically. So same thing. Let's go to the next slide. You got it? So the screw holes are now drilled. I have not activated the Speed MTP yet. So I remove those drill sleeves, and then I'll drop the screws in place, and it's just one distal, one proximal. But I go ahead and make those bicortical because I can feel that with the drill. I can get an idea of the depth. I have different screw length options. They're screws that you're very familiar with from the Treace suite of or portfolio of screws. And so I make those bicortical. And let's go to the next slide. And then you can see here just the same concept you have. So I remove that one provisional wire. I have my plantar screw, so it's not going to plantar flex this toe anymore. Watch. So I activate it like any other speed plate. You can see here, toe does not change position. It just gives the construct a little bit more stability. So I've got four times, two on each side, plus I have two screws, one on each side that are bicortical. Go to the next slide. Low profile. And it's a stable construct. So you see that here, and you can see what it looks like, easy to see around. And same thing, there's the ideal, well, at least what I think is the ideal toe position. And then go ahead and show the video there. You can see that that's a very stable construct. So just something to think about. It's another opportunity for you to work with a system that you're very familiar with if you do Treace type procedures. And if it's one that you're not familiar with, a good one for you to try. I think it's very easy step by step, and I think you'll like it. When I work with my fellows and they see it, they all say they're impressed with how low profile it is, and they think it's a technique that's easy to use. I've got one more assignment here for myself, so let's go to the next slide.
Dr. Easley, I was going to say, so both Dr. Relation and Dr. Troxell have had experience with the Speed MTP system. Anything anecdotally?
Yeah, I'm sorry. I didn't mean to be so selfish. Yeah, I want to hear about your experiences too. Tell me what you think.
I pretty much switched to these. Yeah, I pretty much switched to using this for most of my MTP fusion at this point. I was doing a lot of the biplanar fixation. This has been just as stable. I walked them immediately afterwards. It's very low profile. It's very quick. You do it a couple of times in the lab, and it's pretty intuitive. It's been a great system.
Ronnie,
I've been having great results with it. I'm a little old school in keeping patients off of these. Early in my career, I had a few non-unions from patients doing a little bit too much, but I'm really getting back to walking patients pretty much immediately or close to immediately, just because of my confidence with these. Super low profile. I like to use the longer option. I just feel more comfortable with the longer option. In doing so, that I still throw that oblong screw, that lag screw, super easy of a throw. Very easy to kind of place that screw in there, especially with the longer implant. But yeah, very happy. Just did another one today. I think it's very straightforward. The reamers are super sharp and set, so makes life easy. Very, very quick case.
Yeah, and so again, there'll be a targeting guide for you pretty soon. So if you have any concerns about putting that in freehand, you can have it so you miss all of the fixation. Will be coming through the Speed MTP. Yeah, I agree. I think it's something you should look at. It's certainly everybody who's worked with me on doing these cases has gravitated toward it as well. But I've liked using it, that's for sure. Good. Well, thanks for sharing those experiences. Just real quickly, just along the algorithm we talked about, what about a double? Where here's a pretty stiff and arthritic TMT joint. So if I do a first MTP joint arthrodesis, it may not move quite as well to close the IM angle as you may be accustomed to. A couple tricks with that. I could remove the lateral sesamoid. I could mobilize this more. I can rotate. But in this case, I just felt pretty confident going in that this was not going to move well. So I was thinking that I would consider a double arthrodesis. Go to the next slide. And so here it is. I've prepared the first MTP joint. I've actually got my rotation to where so I still focus on rotation. I've got that where I want it to be. Sesamoids are reduced. And I've pinned that provisionally there, but I've got it lined up. And then I went ahead and did a Lapiplasty more proximally. So you see that with the 3-in-1 guide that you're used to. And go to the next slide. And so in this case, you've seen this, you've used this probably. I'm using the Speed MTP here. The Speed plate here, and it's anatomic, so it matches the contour of the cuneiform. You see there, I've got one of the tacks in this in the inner cuneiform joint. This just helps me guide that well, so I don't end up with the Speed plate in the inner cuneiform joint. Just checking the lateral, make sure I like what I see when I'm putting the medial the speed plate on. Let's go to the next slide. And then just to the point, just to take a step back away from the Speed MTP, this is just two S4A plates using a biplanar fixation, which many of you are accustomed to. But again, if I did that case now, I would use the Speed MTP. Let's go to the next slide. And I got the added benefit of having to do the whole forefoot, which was not so much fun, but using doing the first ray like this makes it a whole lot more fun because it's quite easy to do. And with a reproducible system, this is instrumented, so it makes it a little more fun. Anyway, but there it is. That's the double as part of the algorithm. And then I think we'll finish up with, next slide, going over the algorithm for the very last portion there where I've mentioned the double, the MTP joint arthrodesis, but then there's the quad. And so we turn that over to Kurt.
Yeah, thanks. So this is a case on the quad. So this is a patient comes into your office and she has this history of depression, anxiety, and you look at her history and you know why. So she had her first bunion surgery in 2008, had lapidus, osteotomies on 2 and 3, something with the toes. She wasn't sure, but she still had pain. Surgery number 2 was an Akin, and lo and behold, she still had pain. And then she had a third surgery, all from the same doctor, took out hardware on 2 and 3, said maybe that's the cause of your pain, and there was a transverse screw going across the first and second metatarsal bases. So they took that out, but she still had pain. So she went for another opinion. They said, well, let's just leave this foot alone. There's nothing to do for it. Let's do your other foot. So she didn't like that idea because the left foot was the one that was hurting her. So then she ended up in my office. So if we go to the next slide, what are we going to do with this, right? So she has pain at the first MTP, the medial and lateral first interspace, the midfoot. She has the adductus. She has third toe pain. So what are you going to do? Just wait for PSI on this one? Probably wouldn't have been a bad idea. This is a while ago, so PSI wasn't in the works at that point for me. So I had to really go through her x-rays with her and explain to her what metatarsus adductus was. She was never explained this. The hardware was prominent at that lateral phalangeal base, and actually that was pushing against that proximal phalanx of the second toe. So there was a lot of pain in there. The big toe joint itself was not moving very well at all, very stiff, very painful. A lot of stiffness in the midfoot and a lot of pain in the midfoot. So she doesn't want to have a fifth surgery, so, that leaves me with the quad. So this was more complicated because she already had a fully fused first TMT. So there wasn't a joint to correct through. So I basically had to create a new joint. So I didn't have any fluoro shots of this, but I took a sagittal saw blade and lined it up and used it as a cut guide. I basically put it into the bone where I thought the joint should be. First, I had to get all the hardware out, which that was probably the longest part of the case, was getting the hardware out. Those screws were buried. There was a lot of overgrowth. This is from 2008. So I ended up having these pretty decent sized craters in the first metatarsal after I was done getting those out. I had to open up that first and second metatarsal base and get that synostosis out of there, to mobilize the first ray, and basically created a new first, tarsometatarsal joint. And then once that was released, I go on to your adductus. So you do your mini adductoplasty technique. I did the mini. I did a 3.5 centimeter incision. If we go back a slide, she had a very significant metatarsus adductus here. So one of the things we haven't really touched on yet is, with the mini adducto cut guide, it's a 6-degree cut. When I got done with that, she still had a pretty significant adductus. So you can put it back on and do what they call a double cut. So I typically take that out of the metatarsal bases for your second cut, and it gives you an extra 3 degrees of correction. So we can go to the next slide again. And you can kind of see where she ended up. So I was very happy with where that was. Then I moved on, so we can go to the next slide, and did my first tarsometatarsal joint fusion. And I used the 3R plates because at this point I had to basically carve out those screws that were in there. So there were some pretty significant bone voids. And I did put some bone graft in there as well because of the revision. And the 3R plates, I have a slide on that, but they're a much larger span, so you can span that graft and get more stable fixation. I did another M1 to C2 screw. And then I moved on to my first MTP fusion, and this is the third different way we've seen to fuse that joint. So we've seen the Speed MTP, the biplanar, and then I use speed plates on this particular case. I felt that was a really strong construct, did the quad dorsally and the double medially. I did correct her hammer toes as well and pinned across those joints just for stability in the interim.
Was that the most fun part, doing the hammer toes?
Oh, it was great.
Yeah, but I mean, to your point there, I know you have to make a bigger incision because you got to take care of the whole first ray, but look how really low profile and small that incision is for the midfoot. For big adductus correction, that's amazing. Great work.
Right. I was really, my favorite part of this is being able to do that through such a small incision. If we go to the next slide, you can see, this is the fourth surgery on this foot. So she had a lot of scar tissue along that entire first ray. So, we had all that adductus correction, and if you look at that adductus incision, that there's really nothing going on there. She had that big hematoma from the first ray. Those 4 images are from, on the table, day 5, 2 weeks, and 3 weeks. So nothing really happened with this. She was fine, but obviously I was keeping a close eye on this because I was watching that skin. But you see, the hematoma deflated. Everything seemed to be fine. And I have further images, but I had her non-weight bearing for the first 2 weeks just because of the revisional nature of it. And she was in a lot of pain initially. That was a lot of surgery. But she was coming in with crutch assist, and she was putting some weight on it by week 2. I pulled the pins at 4 weeks, made her full weight bearing in the cam walker, which back when I started practicing, I never would have done. But with the biplanar fixation, it's been my standard. 8 weeks, I had her in a sneaker, and she was shocked because it was the quickest she had been in a sneaker from any of these surgeries that she's had done so far. At 16 weeks, she was really happy. The foot was straight. She was feeling good. Released her to full activity. She's coming in next month for her 1 year. I haven't heard from her, so I'm assuming she's doing well. You can see at 16 weeks that post-op image. So all that skin, that soft tissue just resolved. You can't really even see that adductoplasty incision. That first ray incision, again, it was the 4th time that had been operated on. So I expected some increased scar tissue, but my anticipation would be that I would see it even better next month when she comes in for her 1 year post-op. So the x-rays that you see are 4 months out, and you could already see pretty good bone consolidation almost complete at the first MTP and at the adductus correction.
I have a quick question for you, Kurt. I've done several quad surgeries too, and this is great. I mean, it's amazing work. But I just thought to myself, my God, I've done so much surgery to this foot, and it's going to make the foot relatively stiff. And this is what patients are worried about too. You can do all this, you can do multiple arthrodeses. But has your experience been? You said she got in a shoe relatively early, and her function was quite good. Once she had healed enough and could be out and doing things on the foot again. Do you find that if you can get this correction right, the 3-2-1's good, everything's lined up, and then you do an MTP joint arthrodesis, that it really, if you do it anatomically or get it close to anatomic, that it really just functions exactly like an isolated MTP joint arthrodesis?
Yeah, as long as you're correct in your sagittal and frontal transverse plane, everything is lined up properly. I mean, she was in so much pain preoperatively that at 8 weeks, her pain level from her pre-op was basically gone, and she was walking with almost no pain on the foot for the first time in about 15 years. So, I think it, it depends on the patient, right? If you're dealing with a really arthritic joint, she could barely move that toe anyways, and it was that painful. So, she was thrilled. Yeah,
no, it looks great. Good work.
Thank you. So I wanted to just touch on the System 3R. That's the revision plating system. So it does have a bigger span between the inner screws, about 11.5 millimeters. So you couldn't, if let's say this was a shorter one or there was some atrophy from a non-union or something, I've bone grafted in there, and these will span that graft site. They are a larger diameter screws, so you do have some more bite in the bone, and you get a little bit longer length on the screws as well. Just some touching points on the quad. It's not I don't use it very often. I've only done it a couple of times, but it's a very powerful procedure for these really complicated cases. It's important to have a plan going into these cases, but they don't always go as you think they're going to. So I didn't think those screws were going to be as hard to get out as they were. So I had to switch over to the 3R system to span the defect site. So be prepared to pivot. The plumb line is great for intraoperative assessment too. So not only is it good for showing the patient, but if you can do an imaginary line or throw a freer, or just hold the freer up over your C-arm screen, and you can say, okay, do I have enough correction here? Is my adductus out of the way enough to get a good correction at my first MTP? And if not, you can go back and do a double cut. And then based on what you talked about, Dr. Easley, earlier, I think this would be a great case for PSI going forward. I wouldn't think twice about going down that road.
Yeah, and to be clear, that PSI cases have already been done for adductus correction as well. So just to your point, that's good.
Yeah.
Yeah, great stuff. Could you just clarify one thing? Why do you when you recut it, you say, I don't have enough correction, I'm going to recut. Why do you only cut on the metatarsal side? Why wouldn't you just go ahead and cut both?
Well, you can cut both, but I think it depends on what your anatomy looks like. So sometimes those cuneiforms you have less real estate. So if you're dealing with somebody with a small cuneiform anyways, and you're going to take a second cut out of there, you may be limiting your fixation options with that. So, I don't remember what this particular patient had going on, but, if you go back a couple slides, you probably can see, but that would be the reason to make sure that I wanted to get quads in there. I personally like to get quads if I can, on these. I've done doubles, but I just feel like the quads are more stable. So I like to leave myself enough room in the cuneiforms to get that fixation.
Yeah, no, I think that's a good point. Yeah, especially a second cuneiform. Even in just one where it's just a single, you've only cut one time, you sometimes have to cheat that quad. I'm with you. I do. Ronnie showed a great case of just not having to do that, but I usually like to use a quad as well, or at least two points of fixation in the cuneiform. And you just have to sneak that a little bit distal. And if you start cutting more and more in the cuneiform, you're going to cut yourself short on fixation options. So good. Well,
and you have that availability now with the microquad, right?
Correct. So the microquad. Yeah, microquad's perfect for that. So it gives you that extra point of fixation without taking up that much more real estate. But so it gives an opportunity for questions. And I want to make sure before others sign off, we want to thank Lauren for doing a great job of putting this together. Excellent work. Thank you so much.
Oh, thank you. No, this was great, you guys. If there's any other questions or comments that you'd like to type in, please do so. We'll hang out for a little bit here and wait for those to come in. But we, of course, really enjoy doing these. This is the first time we've ever done a full algorithm presentation. So this has been incredible. Thank you all. Thank you, Dr. Easley, Dr. Relation, Dr. Troxell. Thank you for all of this. Really, really appreciate it. For those of you that are still on, go ahead, Dr. Easley.
Yeah, just especially for those who are still on, and there are quite a few still. You may not have a question now, but Lauren, could you share with the attendees if they do have a question, maybe they have a case that's approaching, maybe one they've already done, they just would like to review. What resources does Treace offer where they, maybe through their rep, could reach out and get some feedback and some advice, some insights, much like this, but maybe even more on a peer-to-peer or one-to-one basis?
Yeah, exactly. That's something that you all, as our faculty, enjoy doing. We do them almost every single evening, every single day, is our peer-to-peer interactions where you have a case you'd like to discuss preoperatively, you have a case you'd like to discuss postoperatively, and everything in between. So reaching out to your local sales rep and then working with the medical education team, we will put you on with a member of our faculty, get you on, exactly like you said, Dr. Easley, a peer-to-peer interaction, and being able to talk things through, algorithm, patient selection, procedural selection, all of these things. All of you have participated in these in some capacity, whether virtually, in person, at our events, and I think they're highly impactful, and I'll turn that over to you guys to talk about that. But yes, that is available to you at your disposal anytime.
Yeah, I've done several of the peer-to-peers, and you can submit imaging. We can take a look at the imaging, talk you through it with a Zoom call. So it really is a great benefit. And then at the events that Treace puts on, these the Bunion Master Seminars, they're a great opportunity to get to be able to pick all of our brains. Really, we have panels of physicians that'll answer questions. We present on all these different techniques. You get hands-on in the lab with a cadaver, so it's a great opportunity to really fine-tune and try out new things.
But we'll teach you what we can while you're here visiting. Thank you for coming to the U.S. Good. Well, I tell you what, in order to finish up, why don't we have Ronnie say some final closing remarks since Kurt and I were windbagging at the end.
Try nano. I've been in invasive. Try nano. It will completely change your practice. Patients are so happy. I love seeing post-op MIS patients. They are just so happy, so quick. It really kind of changes the way you start to think about things. At least it has for me over the last few years, and now especially with kind of the reproducibility and my personal comfort level with the nanoplasty.
Try nano.
I love it, and I think Kurt and I will tell you too, though, and you know this too, but you can do the standard techniques through 2 and 2.5 centimeter incisions, and adductoplasty, as was shown, through 3.5 centimeter incisions. So that's great. Okay, I think you've seen it all. It's a full portfolio to help whatever your preferred technique is or whatever your patient's needs are. Lauren, do you have anything else we need to cover, or are we good?
I think we're good. Thank you all three of you. Thank you so much for being here. Thank you to all of our attendees for joining us this evening, spending your Wednesday evening with us. We love doing these. If you can't tell, we're very passionate about everything that we do, all of us. So thank you, Dr. Easley, Dr. Relation, Dr. Troxell. Thank you so much for doing this. Have a great night, everyone.
Thank you, Lauren. Thank you. Great work, guys.
Thanks, guys. Bye. Thanks.
Great job.
Have a good night.
Have a good night.
Try nano.